Information Risk with David Loshin, powered by Insight Jam.
Hey, it's Doug Atkinson from Solutions Review, and we are back with another episode of the Information Risk podcast with David Loshin. David, of course, is our resident data governance expert here at Solutions Review and in the Insight Jam, which you can connect with him at the Insight Jam. And David is the principal data strategy consultant at Knowledge Integrity and is just the font of knowledge for all things data governance and what you are now calling information risk. And I want to talk a little bit about today about healthcare with regard to information risk. And I know you always bring some good examples, and you have one that you want to talk about straight out of the box. So I'm going to turn things over to you, but let's start getting into kind of where we are in terms of how data is being used and algorithms are being used with regard to care and the decision making that goes on underneath all that. And then let's maybe get out the crystal ball and start to think about the implications of when AI starts to load in and the ethical questions that are going to arise around that with regard to healthcare.
That sounds great, and thanks for inviting me again to do the podcast. We've drilled down into a number of different interesting scenarios, and today, I think we're pivoting a little bit from what we typically talk about in terms of let's pick an area of information risk that we talked about in some of our earlier episodes, and here kind of focus on kind of building around the understanding of the evolution of the ways that algorithms are being integrated into healthcare claims processing and health and management, and what some of the root causes are of some of the risks and what some of the implications are.
Yeah, and I mean it's a huge dilemma, and obviously there's value in being able to automate some of this stuff because there's so much pressure on the system across millions of people who are beginning to deal with either aging or other temporary maladies, but the system is under massive pressure, and decision making has to be to a certain degree automated, but that comes with implications. And I think, like I said, I think you have an example where it gets a little sticky.
Yeah, and I think that you're kind of touching on the right point, which is we want to be able to integrate automation into the process without abdicating our responsibility to those automated processes. So let me jump into it. I've got a couple of examples we can chat about today. So the first one is, and again, as we always say, when I'm going to make reference to some articles and some papers and some other documents. If you want to get links to those, contact me either through email or through the Insight Jam or through LinkedIn or through any other place that you can find me. I'm happy to put together a list of some of the links for people to review. So this first story comes from an article that I found on it was an article that was researched by ProPublica, which is their media channel, but they also do a lot of investigative work. And the title of the article is "How Cigna Saves Millions by Having Its Doctors Reject Claims Without Reading Them." And the story kind of goes like this in the article, that there's a patient. He's actually a doctor, so he knows a little bit about the medical world. And he had some kind of stubborn pain in his bones, and he went to his doctor, and the doctor said, "Okay, maybe you've got a vitamin D deficiency. So why don't we do a test for vitamin D in your blood?" So he goes off and he gets his blood test for vitamin D, and they submit it to the company, and the blood tests confirmed what the doctor said, that he did have a vitamin D deficiency. But then he looked at his explanation of benefits, which basically said, we're not going to cover the cost of that test because it was not, quote unquote, medically necessary. And most people would look at that and they'd kind of say, okay, I'm not really sure what to do about that, but apparently, we'll drill into this a little bit further about the propensity of people to how their responses to those type of decisions are and what they actually do, because it's important in this story. So the way it goes is that this physician, he looked at, he examined the details of this, and he was a little suspicious. And it turns out that his claim was one, and again, I'm quoting from this article, his claim was roughly one of roughly 60,000 that the medical director from the insurance company denied in a single month, according to internal records that ProPublica had reviewed. So basically, it's not like there's an individual who's carefully reading through each one of these claims, but rather they've got some kind of automated mechanism that is taking the claims and just scanning the data associated with it and either approving it or denying the claims. And it's beneficial to these insurance companies to deny claims, because it just means that they're not going to pay for the procedures or for the tests or whatever, and so they end up saving, so it ends up saving a lot of money. Then the problem is that if there is you're doing denial typically, manually, that takes a physician's time to go through the material and review everything and then make a decision. And so if it takes that time, that actually can cost the insurance company money. So they're looking to do a double benefit. One is to reduce their costs of reviewing claims to determine denials, and the other is to automatically deny claims and then not pay for the tests.
Yeah, no, this is ProPublica's very cheeky in this article. They have a little widget that's counting the amount of time you've spent on the web page that you're reading.
Right.
And then
how many claims they've automatically denied.
How many claims Cigna has denied during that time, which I'm up to 227 claims that Cigna has denied in the time that I've been looking at this. We started this podcast.
Right. So let me jump back into this. You started our conversation today by talking about AI and AI modeling. This is not an AI model. It's not really a sophisticated algorithm. Really what it is, it says that it uses technology that allows them to make fast, efficient, and streamlined coverage decisions based on members' benefit plans and clinical criteria in compliance with state and federal laws. Basically, they created a list of tests and procedures approved for use with certain illnesses. The system would automatically turn down payment for a treatment that didn't match one of the conditions on the list. Denials were then sent to the medical directors, who will reject the claims with no review of the patient file. So basically, this is a database algorithm. What it does is it gets it automatically looks at the conditions and the procedure, the illness, the patient's illness, and the conditions for which the procedure was being being
and David,
issued.
let me just jump in, because let's not bury the lead here. The law says, and the regulations say, that doctors must review the medical records. Medical directors are expected to examine patient records, review coverage policies, and use their expertise to decide whether to approve or deny claims. However,
so that's
in this particular case, Cigna's review system that blocked this doctor's claim bypassed those steps.
So it's interesting, because the way you phrase that might be, it's subject to interpretation, right? So it says it's got to be done in compliance with state and federal laws, which means that they are kind of skirting, what is the law, and that actually we're going to get to this too, because there's an implication of our second example that actually came out as a directive from the Centers for Medicare and Medicaid Services as a result of what we're going to talk about, after in our second example. To get back into this, the issue here is that not all the data that is necessary for being able to have the right conditions set in this algorithm is necessarily available at all times. So for example, so again, basically what they're doing is they have a list of conditions and a list of criteria, and then whether a determination in the data set that, and again, I'm speculating as to how they're doing this. That's just the way I do things to try to reverse engineer how stuff works, is that basically it matches the conditions, and if the conditions don't match, if the treatment didn't match the ones for the treatment for the list, then it would deny it. So one of the issues here is kind of what you're saying, which is that, depending on where you are, there may be different rules about what an insurance company may or may not do in terms of denying a claim. So this physician, he lives in Maryland, and he said that state officials said that the system, which they call PXDX, it raises some red flags. The state law regulating group health plans purchased by employers requires the insurance company's doctors be objective and flexible when they sit down to evaluate each case. And if medical directors are truly rubber stamping the output of the matching software without any additional review, it would be difficult for the medical director to comply with these requirements. That is the response that the Maryland Insurance Administration wrote in to some of the questions about how this is being done. Now the thing here is that, and again, I'm not always here to like wag a finger at the perpetrators of these examples, because they're doing it in the best interest of their organization, right? I mean, a company like a Cigna or any of these other health insurance companies, their goal is to minimize the amount of what they're paying on claims, and to maximize the profit to the company. And purportedly, you would think that they also want to maximize the health benefits to their members. So, I would probably order it with that one being first, not being the third one. But again, I'm not going to specifically condemn them because they're interested in making money for the company.
Yeah, but let me jump in there because the game they're playing is a bit of a cynical game in that savvy people like this doctor will power through that, and so what you end up with is this inequity. If you just deny kind of a certain amount of claims, some people will push back, and there is an inevitable bias toward who's going to push back, right? It will be the people who either have more resources or more sophistication with working within or just more time and energy to push back against the massive Cigna bureaucracy that is in the way, right? But that's you're exactly the game right that they play, and that's the cynical game, is that certain numbers. It's like you find in any customer service situation. There's walls designed to shed you and shed as you go through, and if you continue to go through the walls, you'll get what you want. Ultimately, you will get what you want, but it's designed to fatigue you to the point where you can't make it all the way to the end, unless you're you either have the brain power, the means, the sophistication, and ultimately the people who can power through that bureaucracy and get to a reasonable resolution in their favor are different than the people who can't.
Yeah, you're absolutely correct. I mean, and I think the question about equity in healthcare is kind of a critical subtext to all the things that we're talking about, because it's not just about the inequitable treatment of people who don't have the resources to be able to address this. I'm gonna refer also to what it says in the article. It says Cigna does not expect that. Well, here the Cigna executive emphasized that the system leaves room for the patient and their doctor to appeal a medical director's decision to deny a claim.
Yeah, they do.
But Cigna does not expect many appeals. In one corporate document, Cigna estimated that only 5% of people would appeal a denial resulting from a PXDX review.
And you could, you could bet the ranch that those 5% are different emotionally, mentally. It may be more educated, but any number of ways. The people that would have the wherewithal to say, no, I'm powering through this and I'm going to get my
Well, it's clearly,
sorted.
what you're talking about are people who have access to time, and they are able to spend, they, first of all, they have time to read through what it is, and they have time to reflect on what the decision was, and then be able to say, well, this doesn't make sense to me. Because, I have to tell you, there's lots of people like me who every time I go to the doctor, I take notes and then I do research on Google so that I understand what the physician was talking about, and I can go back with a bunch of questions. I also have spent time with other people who would like me to come along to help them, and maybe in some cases elderly people who, number one, they're not technically savvy like I am, and number two, they're just sometimes afraid of doing further investigation on what a doctor says, because they'll think, okay, well, if the doctor says this, and I go look at it, and there's 40 articles come up in Google, and 20 of them are from people who have some kind of horror story, which again, you have to be able to be discriminating when it comes to that. But you look at that and they say, oh, this guy took such and such a medicine and their head popped off, and then immediately they think, okay, that I can't do this because my head is going to pop off, even though that's it's unreasonable to believe that happens all the time. But it's number one, it's people who have got the framework in their minds to walk through these kinds of things. Number two, people who have the time and the ability to do it. So if you don't have access to the internet, how would you even do a research on that? You'd have to go to the library to get public access or something like that. Number three, there's a lot of people who just literally don't have the time. They're like people who are working two jobs, and they don't have time, to stop from what they're doing. And to go and to do the legwork to get in touch with, get in touch with their own medical provider,
or the energy,
who's only in the office 5 hours a day anyway.
Yeah, or the energy. I mean, if they're the ones that are ill, they're ill. They're dealing with their illness,
and for sure, yeah.
And it's nobody's there to help them.
But it's not just this. It's that I'm going to turn it back to the data, which is that these systems. So I'm going to start out with saying that it's a system because it's not an algorithm. This system is predicated on having data associated with histories of individuals who have the conditions and what the decisions that are being made based on what is or is not deemed to be medically necessary.
Well, and the system self-satisfies because it starts at some level, right? It starts at some level, and it probably has a reasonable predictive model attached to it, because it has to start somewhere, and it starts somewhere with some level of data. But then once the system begins to do the denials, and there's a certain 5% that are going to challenge it, it begins to begins to pat itself on the back because it was so good at doing the prediction. It rewards itself.
Yeah. Yes, basically. And one thing that they call out in the articles, it said that the system is unfair to patients. The claims automatically routed for denial lacked such basic information such as race and gender. And I'm going to put that in the parking lot for a couple of minutes because I want to get back to that and some of the things that you were saying. But in this case, what they're basically saying is when they're doing an evaluation, they're not taking into account. I'm not saying that the data is wrong here. What I'm saying is the claim is missing information that potentially could be relevant in the decision process. So we've got a data absence risk here, and because of that pushes it back into the information. This is a vulnerability, right? So in that case, this kind of again, this is not a sophisticated AI model. This is really just a relatively simple algorithm which says look it up. Here are the criteria. Look it up. It either the database will say approve it or deny it. It's better for us to deny more because most people, 95% of the people, are not going to contest it. We're going to be in good shape no matter what we do.
Yeah, and so we're going to take a quick break, but before we do, I mean, that's where we've come to, right? It wasn't like this 25 years ago, 50 years ago. It was much different than it is now. But Cigna has evolved to a point where they have this system now in place, and this system works for Cigna. And
I would be confident that Cigna's not the only health insurance company that has an automating process for batch denying hundreds of thousands of records of claims at the same time.
Cigna just happens to be in the crosshairs here, but you're absolutely right. These systems are universally being used, and they are, while we consider them dumb, you certainly as a data scientist consider them dumb. They're smarter than they used to be. And this is where we are. But now we're going to take a break. When we come back, we're going to talk about where they're going. Because if we all think this is ethically interesting, we're about to go into all kinds of tall grass. So we'll be back in a minute.
Solutions Review is inviting you to join InsightJam.com. What started a few years ago as a social media event to celebrate enterprise technology has now grown into an always-on tech community with live events, discussions, videos, vendor showcases, and industry resources. Our vetted roster of experts, thought leaders, and analysts are sharing tips and tricks daily. So if you're interested in getting involved, join the long list of companies and brands who have already participated by visiting InsightJam.com today. Now back to the show.
We are back speaking with David Loshin, the Information Risk Podcast. We're talking all things healthcare and algorithms and denials of claims and sophistication of, let's talk about AI. Speaking of sophistication, let's talk about where we're headed. Do you have some examples?
Let's just jump into it.
Yeah. Do you have some examples that you might be able to pull out of your hat for where healthcare is starting to leverage AI?
So yes, and this is actually a good one because it kind of this example kind of composes all the issues that I think we need to be considering when we were talking about AI and its use in a healthcare environment. There are a couple of articles about that I surfaced about companies that were being sued because the health insurance company was using a faulty AI model to deny elderly patients medically necessary coverage. And the basic story, it kind of goes like this. I'm gonna abstract the particulars of one part of let me see if I've got some notes here or there somewhere. What I'm gonna do is abstract the concept because it happens multiple times. And basically it goes like this. When people are older, they may transition from being covered by their employer's health insurance plan to Medicare. And one of the alternatives, and again, I'm not an expert in this, so I may defer to others to share their thoughts about this in any of the comments areas, but Medicare Advantage is a one plan that Medicare provides, which allows for private health insurance companies to provide policies for healthcare for people who are retired, basically, or people who are elderly. And the way it kind of works in practice is that when somebody who's covered by one of these plans has some kind of operation, or let's say they fall and they go to the hospital, they get admitted, and turns out they broke their hip or something, so they get a hip replacement surgery, and then they have to go to rehabilitation, or somebody who got sick somehow and they need to go, they're done with their hospitalization, and the physicians in their care, they basically say, okay, well, you need to go to what's called a skilled nursing facility, so it's some kind of acute aftercare. And so it's a facility where you go, you are treated well while you are rehabilitating. So if, let's say, you had a hip replacement surgery or knee replacement, you go there to this nursing facility, and you are given some time to be able to get used to walking, to be able to get some strength, especially if you had a long illness. Let's say you had some kind of sickness and you were in the hospital for a while, but you're deemed to be better, but you still are very weak. So they send you to this skilled nursing facility. And the thing about the skilled nursing facility is that the goal there is for people to get better so they can they can get out and be able to move around on their own. And I'm kind of digging around looking for some of these articles, and basically,
yeah. I mean, I
companies.
actually let me
Go ahead.
While you're doing that, let me jump in because this is near and dear to my heart because my father is currently in a skilled nursing facility, having just he had a fall, and after he got out of the hospital, they asked, it was he needed to kind of rehab his ability to mobilize and walk on a walker. He's elderly. And there are certain. It's interesting. The Medicaid. I know a lot about it now because Medicaid will cover a certain amount. Your private health insurance will cover a certain amount. But there is a lot of pressure to get them up and out. You can't stay there forever, and so there's a lot of pressure from the system on these skilled nursing facilities to spin people up and out, and not max out on their budget.
Well, that's basically the story, right? Which is that when health insurance pays for it, they don't really care, right? I mean, they want to fill beds and provide services.
Well, they
as long as they're getting paid for it.
I think they care in that they don't want any negative marks from the system that they're somehow milking it. Do you know what I mean?
Of course.
They're trying to stay as clean as can be because they don't want anything getting in the way of those reimbursements.
Right. But they want the reimbursement, and that's the problem. Is that a lot of the people who are elderly who go to skilled nursing facilities, they are expecting to be going there so they can rehabilitate, so they can get out and walk around, and sometimes that takes longer than somebody might expect. Again, and the physicians know this.
It's exactly the conversation we just had, where the skilled nursing facility was saying to my sister and brother and me, "Your father's ready to go," and we were looking at them like, "What are you talking about? He's nowhere near ready to go. We know what his baseline was, and we know where he is now, and it's not the same area code of ready to go." And
maybe you guys can join this class action suit. So basically, I also appreciate the fact that you jumped in there because it gave me the chance to find on my desktop the document that I was looking for. Yeah. And so the story basically goes: there's this woman, she has a shattered left shoulder, and she also has an allergy to pain medicine, so she can't take opioids. And so they have this algorithm called that they use called NH Predict. So the company's name, I think, is Nava Health. I think it was. I read somewhere that it was purchased by one of the health insurance company, by United Healthcare. But basically, it's an algorithm, and this is an AI algorithm, which says it takes a bunch of inputs and based on the case, and it does a prediction as to how many days that patient would be ready to leave the skilled nursing facility. And so in this case, this 85-year-old woman who has an allergy to pain medicine, it said in 16.6 days, she would be ready to leave her nursing home. On the 17th day, her Medicare Advantage insurer followed the algorithm and cut off payment for her care, concluding she was ready to return to the apartment where she lived alone. Meanwhile, medical notes showed that her pain was maxing out the scales. She could not dress herself, go to the bathroom, or even push a walker without help. And so we have this situation where we have a conflict, which is we've got an algorithm which is making some kind of decision, and then we've got reality. And when I read this, I don't know if you're a Marx Brothers fan, but it immediately reminded me of this scene in a famous Marx Brothers movie called Duck Soup, where Groucho Marx is involved with this woman who's played by Margaret Dumont, and he's at her house, and then he says, "I'm leaving, I'm going back to the palace." But meanwhile, his brother Chico, who is playing some other character, actually dresses up just like like Groucho Marx, and shows up also at Margaret Dumont's house. And Margaret Dumont says, but Mr. President, he's supposed to be the president of the country. Mr. President, I thought you just left. And so, and what Chico says, which I think is brilliant, he says, "No, I never left." And she said, "But yes, you did. And I saw you leave." And he says, "Well, who are you going to believe, me or your own eyes?" And that's what I'm thinking about. It's like with with these algorithms, it's like, who are you going to believe, the AI or reality or your own eyes?
And I think, I think it comes back to because of the amount of people in the system and the pressure on the system, there has to be some level of automation. But and in fairness, I think we're at least where the rubber met the road for in my example, a caseworker does come in and say, we're predicting that it's time for him to go, and I'm sure that pressure is coming from the system.
Right,
but they're
and
preparing
for all you know, it's coming
next week.
Right,
next week
right.
Things are going to change for you, so get ready. And that's when you have to start again leaning into the system and saying, "Hold the phone."
No, but presumably, these would be, think again. I without condoning the organization. Let's think about it logically, which is if I have 500 beds in my facility, and I've got 1,000 people who need a bed. If I have 500 people there who are there 10 days longer than they need to be, then that's 10 days worth of 500 beds that another 500 people can't get access to. So if I look at it logically, even if I'm trying to be good in trying to maximize the overall value of providing healthcare services to a broad population, it meets our objective to maximize the amount of time that more people can get access to care. So under the right circumstances, this is, I'm reading from one of these articles. It says it's said at the beginning of the process, promising to deliver personalized care and better outcomes, right? Because if let's say you needed to, let's say your dad needed to be there for 35 days, and the algorithm said, he only needs to be there for 35 days. After that, he's not going to get any benefit out of being there. And if we move him out, we can get somebody else who needs to get into the facility. So now we will have helped 2 people, and we're most of the way there. So yes, he may not be back to the way he was, but he's able to do enough that he doesn't need to be in this facility. But the problem is that when they take, this is a problem of technology, which is what you're using the term gaming the system. I have the technology, and now I see, well, if I use this the right way, we can maximize the amount of money that we're getting paid through Medicare Advantage claims, and we don't really care if the person needs to be there, because they'll just pay. If they can, they're just going to pay, and if they can't, they're going to get out of there. We'll get somebody else to pay. So we're maximizing revenue per bed.
And in fairness, these nursing facilities, while they present themselves singularly as a nursing facility, they're part of massive networks.
Oh yeah, they're businesses.
It's big business, massive business. When you start to do the math on $600 a day per bed, per unit,
it's billions of dollars.
It's humongous, and the amount of money that's pouring through this system is one could argue that I think there are many politicians who do argue that it's unsustainable.
Right. So I mean the issues here is that they're starting to rely on the algorithms solely as the determining factor. This is where we want to go back to information risk. That's the risk. Is that we are looking at these as decisioning tools that are infallible.
Yeah, no, and in preparation for our podcast today, I asked ChatGPT to just spin through some of the ethical concerns related to AI in healthcare over the next 10 years, and it's it spun 15 of them out without even batting an eye, as it often does. But privacy and data security is number one. Informed consent, data bias, quality and accuracy of data, patient autonomy and agency, algorithmic accountability, impact on the healthcare workforce. I mean, we definitely saw some of that at the the kind of molecular level with my father, where, the staffing concerns at these places is significant these days. Access and equity, long-term implications, consent, cultural and ethical sensitivities, it goes on. And that's ChatGPT kind of telling on itself
Yeah.
what is about to occur, because as we were talking in the previous segment, it's not going to stay static. It's only going to become more reliant on modeling and artificial intelligence and prediction and systems for decision making.
Yeah, and so a little bit more about this situation, which is that there's class action suits that are being brought by a collection of individuals who are saying, and I'm going to read from the complaint. It says arises from the health insurance. I'm paraphrasing this, from the health insurance company's illegal deployment of artificial intelligence, AI, in place of real medical professionals to wrongfully deny elderly patients care owed to them under Medicare Advantage plans by overriding the treating physicians' determinations as to medically necessary care based on an AI model that defendants know has a 90% error rate. Okay, so that's number one. Number two, that's paragraph number one. Paragraph number two, despite the high error rate, defendants continue to systematically deny claims using their flawed AI model because they know that only a tiny minority of policyholders, roughly 0.2%, will appeal denied claims, and the vast majority will either pay out-of-pocket costs or forego the remainder of the prescribed post-acute care. Now, that's a tenth of what we were talking about in the PXDX example. That they say 5% of the members will appeal a claim.
Well,
here it's point.
Well, and I want to go down this further, because your point is a good one. And this idea that, they'll just pay the out-of-pocket costs. The out-of-pocket costs are astronomical.
Oh yeah, it will drain your estate
a month in these things. I mean, it is ridiculous. I don't know. I mean, again, God bless people who can weather that storm but it's absolutely outrageous, because they're getting max dollars because it's subsidized at the beginning. And you sign up to say, when you are done, if you want to continue to keep this bed, it's still drilling down at $600 a day. It's better. I mean, and it's, I tell you what.
I know. It takes your breath away.
It takes your breath away. I tell you what, I was having an entrepreneurial moment in there at one point when I was with my dad, thinking, geez, I could charge half that and make way more money than I do here. Yeah.
Oh, well, I don't know. Let me know. We'll talk offline. No, so a little more in here. I mean, of course, this is lawyer speak, because this is their complaint, and so they're going to throw words, or I'm not saying what they're saying is true. This is just what the complaint says. So, they're saying that it's got a high error rate and the systematically denying claims, and they are, overriding treatment, and it's a fraudulent scheme. Well, they have to say that stuff in the complaint.
Yeah. That's good.
But I mean, to drill into it a little bit, I mean, like the algorithm that they're using is this thing called NH Predict. It's a predictive algorithm. I believe it's an AI model. And it's I'm reading back from the article. It says it uses details such as a person's diagnosis, age, living situation, and physical function to find similar individuals in a database of 6 million patients and compiled over years of working with providers. It then generates an assessment of the patient's mobility and cognitive capacity, along with a down-to-the-minute prediction of their medical needs, estimated length of stay, and target discharge date. So ELOS, estimated length of stay, and that's the number they were using. But the thing I want to point out here is that they're using a data set that consists of 6 million patients compiled over years of working with providers. So 6 million, you might say that's, in terms of data, you'd say, okay, that's a lot of data. But in reality, it's really not a lot of data. And in even more reality, what data is this coming from? It's coming from patients who go to the doctor and get treated for their illnesses and are on top of their medical needs and make the time to go. And it doesn't take into account all the people who don't show up. And those are people are still sick. And those are people who still have similar issues. And they're people who don't have the same equitable access to healthcare. And so their data is missing. And so this goes back to what you were saying before and what I kind of alluded to, which is in the PXDX case, they were saying, well, it doesn't take into account, let me go back and read what it says. It says it lacked basic information such as race and gender. And really what that's saying is, or the underlying implication there is that even if it had that data, it's not necessarily going to account for it because there's no history in the data set of that is significant enough to be able to discriminate based on those criteria. And so, people who are of different races or ethnicities or economic status who don't typically show up in that database are not going to be treated equitably because the information of the patterns associated with their characteristics just isn't there.
Yeah,
and this is the core.
And this is number 3 on my ChatGPT results: data bias and fairness. AI algorithms can inherently bias, can inherit biases present in the data used for training. This can lead to discriminatory outcomes, particularly for our marginalized and underrepresented groups. I mean,
yeah, and here's an opportunity for us to link back to the example that we talked about with the bank, with Wells Fargo. What was that, like last week or 2 weeks ago? Yep. It was 2 weeks ago, or 2 episodes ago, where the algorithms being used for the determining whether somebody's creditworthy had the process of doing the loans. They were supposed to ask for the information about race and ethnicity and gender and that kind of stuff, and they weren't doing it. Well, there's a reason for collecting that data so that we can ensure that those people are properly represented in the data sets that we are using to build the models. So I mean,
well, and what do you do when the data doesn't exist because it's just not in the system? Because to your point, they're not participating; they're self-caring somehow.
Yep.
Yeah, and that's a conundrum. I don't necessarily know. I don't know a good answer.
So I think in our when we get back from the break, I think we're going to talk a little bit about some of the data issues and how we might start thinking about it, or how organizations might start thinking about it.
All right, well, let's do that. We've got a little bit more time after the break. We'll come back with you, David, and we'll talk about just that. How do we move forward in solving some of these questions?
Want more Insight Jam? Follow us on Instagram for exclusive content like a daily dose of best practices and buying advice from industry experts and leading solution providers. Or subscribe to our YouTube channel for long-form highlights from our expert panel discussions. And if you prefer to listen, please rate and review the Insight Jam podcast on Apple, Spotify, or Google. The Solutions Review team is hard at work collecting the best enterprise technology information from around the globe, so don't miss out. Now, let's get back to the show.
We're back on the Information Risk Podcast with David Loshin. And David, we have been working our way through the system. Any other examples that you want to highlight before we kind of get down to maybe some resolutions that we can come up with?
Yes, I actually do, because this is a different example. This example was an analysis that was done. It was summarized in an article called AI Gone Astray that was published on Stat. It says how subtle shifts in patient data send popular algorithms reeling, undermining patient safety. And what I did is I dug out the technical supplement to this article, which really just kind of drills down into, the process that the researchers went through to do this analysis. So basically, they looked at an algorithm that was being used to determine whether a patient had sepsis. So it was an algorithm that was being used to determine it, when some emergency care needed to be injected into the care process in hospitals. And there's an algorithm and AI algorithms that were being used. Now they didn't have the algorithm itself, they didn't have the model itself, but what they were able to do was train their own versions of two different versions of an AI model using the same criteria and with the same expected behavior. And they looked at the data. So they had data. I'm going to read from my resource, health records of over 50,000 patients between the years 2008 and 2019. So they had a good 10, 11 years worth of data for 50,000 patients. Again, not a huge population, but huge enough because it was limited to people who were in the ICU and were subject to had to be tested for sepsis in the ICU. So it was a limited data set, but it was a good data set. And what they analyzed was over time, they looked at different windows of time, and they looked at the data and the training of the model and the models. I'm going to use the term. Maybe accuracy is not the right word. I mean, I'm not a statistician, so there's all sorts of great terminology that I don't really understand. But basically, the goodness of the models, not over the full time period, as well as in different chunks or windows of that time period. And what they were looking to do was to see if there was any degradation in the models over time. And that's a concept that's worth kind of drilling into a little bit. The model is built using a data set, but things change over time. And so if I want to make sure that my models are continuing to track with reality. So if I'm building a model in 2008 and I am using that model, then 10 years later, there may be things that have changed all over the place in the environment and healthcare provision and in medications that will have changed the underlying presumptions associated with the criteria that were used to build the model, which then degrades the value of the model because it's no longer accurately predicts what's going on in real life. And so what they were able to do is through doing these experiments and looking at these different windows, they determined that there was what they call time drift. They look at two aspects of that drift: technical drift and data drift. What they call technical drift, it's the switch in the use of the diagnostic codes from ICD-9 to ICD-10 in 2015. So this is truly a data issue. It was when the diagnostic codes for patient records, ICD-9, it's a collection of codes that are being used, and that's part of the whole ecosystem because the ICD codes are the ones that are also being used for filling out health insurance claims. So it's definitely useful to have some knowledge about the model drift associated with a transition from using one version, which was ICD-9, to when they went to the next version, which was ICD-10. And the results basically said that when they went to time period from when they went from ICD-9 to ICD-10, there was I'm going to use the word significant in one or in a couple of the different versions of the models that they built. There's a significant drop off in the predictive reliability of those models, meaning that a change in the data that was being used to be submitted to the models was not accounted for because the models were not built using the data that was being submitted to it. And so you end up with this degradation of the models because people are not paying attention to the core relationship between the data, the models, and how things change over time. So it just reinforces this whole question about relying on an artificial intelligence model has a lot to do with having a level of trust in the underlying data that was used to train and maintain that model.
So let's talk practically about how organizations work through that challenge. I mean, you're a data scientist. You've seen a thing or two. I mean, what do they do to prevent that degradation from occurring? How do they maintain their data sets, and how do they try to ultimately improve the outcomes, not only for themselves but for in a perfect world, their customers.
So there's two things that we really need to look at, and they're really completely different domains. I mean, the first is what you're asking about, which is what I might call model governance or model data, oversight, which is basically saying that, our AI models are if we are looking to ensure that they are providing the optimal value, that number one, we have to go back to, the claims that are being made in the complaints, in the lawsuits against that are referring to the NH Predict model, which is if they're saying that the model is 90%, what was the number that they used?
Yeah, it was 90%
inaccurate. 90% inaccurate. So like if you're using them,
which is an
you
outrageous.
better know.
It's outrageous.
That's I mean, if that's true, I would say maybe that is criminal. But again, I'm not judging. But what that says is we really need to have some processes for overseeing what we are expecting to be able to get out of these models. And that means, number one, we have to make sure that the model is delivering predictable results that are reliable. Number two, we have to make sure that that reliability transcends the full population that we're looking to be submitting to that model. Meaning, we can't build a model on rich white males over the age of 55 and then expect that to provide the optimal predictability of healthcare decisions for Hispanic females who are 25 years old. Right, we have to be able to have the full.
But I'm curious about that. Do you weight it? Would you weight it? I mean, because so we do. This is back to the ethical issue we were talking about earlier. If the data isn't in because it's not, those people aren't effectively using the system, do you still push the data in even though they aren't going to be using the system? I mean, I don't know that you adding the data increases their usage of the system, and so are you then artificially? This is the question, right? Where do you are you
well, you have to have an accurate,
that is never going to be in the system to make models more equitable, even though the system is never going to be equitable?
Well, so the equity question is saying, who's the target audience for which this model is going to be used, and have we appropriately collected the information that we need to be able to effectively serve that population.
And
if
that's
we haven't,
that's where things get more sophisticated, is when you start to take individual cases and you're saying, this is now, using my father as an example, a 98-year-old white male. And so the model that we will use to predict his, we're taking age, we're taking whatever sex, and we're going to and all the other, I would assume, all the other medical elements in his record, and we're going to individually model him against a model of others like him, right?
Exactly. Right. Exactly. And that we shouldn't be treating him as if he is a 25-year-old Hispanic female.
Right.
And we shouldn't be treating 25-year-old Hispanic females as 98-year-old white males.
Well, but again, the question I have is, do you incorporate the 25-year-old Hispanic female data into the model that you're using as part of the weighted model, or do you just say, no, we're just going to bifurcate?
So this is where the art kind of comes in a little bit, which is being able to really get a good understanding of this is the complaint that I often have about some of the data science students that I see, filtering through my classes, which is they're taught to use tools and they're not taught to think about how tools are used. And so they will see a data set and they will say, oh, I need to cluster this. So I'm going to pull out these features from the data set and I'm going to run this clustering algorithm. And then I'm going to look at the results and then I'm going to try and figure out what the results mean, as opposed to what I would do, or, and then like I have the benefit of being 40 years older than my students, which is I say, what's the problem I'm trying to solve and what's the population for whom I'm trying to solve it? And what are the characteristics that I think would be the most probable to influence the decision that I want this model to make? And I'm going to take the whole set of those and then try to do the discrimination to determine which ones have the greatest degree of influence on what the decision could be, and then compare that to history to say, okay, well, what we did is we split our data set, and some of it was used for training and some of it was used for testing. And, we're going to do that 5 different ways and see which model comes out best. And then I can't just leave it at that, but I have to say a month later, I have to say, is our output any better or worse than it was a month ago? And if it was worse, then we got to go back and do some more of the investigation to figure out, what are we missing, or what don't we have, or what needs to be refined, or those types of things. So there's a whole process involved.
Yeah. So we started with kind of the dumb system example at the beginning of the show, where it was, one could argue that it is a system that is weighted toward the benefit of the insurance company. Let's call it what it is. And I think everything is going to have that, consideration. Obviously, they're the ones making the decisions, so they're going to obviously, have a little bit of bias, if you will, there. But they also are using a relatively advanced. I don't even know that we'd call it an algorithm, a data model, or some sort of thing that is, ultimately kind of arriving at this. Well, we'll just deny X amount of claims, and that'll be good enough. But now that we have all these tools that are coming into play, particularly AI, and we're having just more and more data every day layered into the system. Where does the responsibility come in for governance here with regard to acceptable types of modeling and acceptable data? Is this something, particularly when it becomes a Medicaid or Medicare decision, does the government start to step in and say, well, you know what, we're going to start to mandate certain data models and ultimately AI approaches?
Well, okay. So it's interesting that you went there, because we're not at a point where we can impose some set of laws that say the algorithm has to do X, but rather we have to have guidance that says you can't just take an AI algorithm, put it into place, turn it on, and then ignore it. And what's interesting, the reason I say it's interesting is that as a result of these lawsuits and a bunch of other activity, the Centers for Medicare and Medicaid Services issued a final rule. There were a couple of things in the final rule, but one of them specifically says, and I'm reading again. I can give you the link. It says Medicare Advantage organizations must ensure that they are making medically necessary determinations based on the circumstances of the specific individual as outlined in a prior section, as opposed to using an algorithm or software that doesn't account for individual circumstances. Okay, then it says organizations must comply with an amended set of characteristics. Again, I don't need to go through the specific section number, which requires that a denial based on a medical necessity determination must be reviewed by a physician or other appropriate healthcare professional with expertise in the field of medicine or healthcare that is appropriate for the service at issue. So basically, what they're saying is you can't do it, right? You can't solely rely on an algorithm to make a determination about healthcare coverage. Now, it doesn't say you can't use it. It says you can't only use it. So and referring back to
so this is this is interesting because one of our kind of Insight Jam initiatives is to talk about the impact that AI is going to have on careers and the future of work, and where it's going to become effectively a replacement for humans. And what that decision is basically saying is, despite the fact that one could argue that AI might even make a more a cleaner decision, they're still going to require the human being to be in that decision in the final analysis, right? And in a way protect those jobs, whoever those are, right? They don't say they're doctors necessarily. They say they're medical.
So this is a good example, and we can get into this in another episode.
Yeah, no, we're gonna get into this
of how work changes because it's one thing to say I have to have an army of medical practitioners who are reviewing every single claim, and the other end of the spectrum is I've got an AI model that's going to completely automate this whole thing. We don't have to get people involved at all,
and reduce reduce massive amounts of cost in the system.
Right. But what it should be doing is like a Pareto thing, which is 80% of the time. If presuming that it's not wrong 90% of the time, but let's say it's a good model, and say 80% of the time it's providing a good result, and it really just needs like I'm not going to automate that. Right. Say okay. Model says yes, it's yes. Model says
auditing.
No. It needs auditing, but the auditing can be done in a more efficient way. And then it's the 20% of the time that says I'm not really sure. I need to have an expert who's going to look at it, where the expert is actually doing the decisioning. And so we're tilting. What we should be doing is, instead of like getting rid of people who are sitting and just staring at screens all day, what we should be doing is retraining those people to be better suited to assessing the result of the AI and determining whether they can okay it or whether it needs to be bumped up in the hierarchy. So it changes work. It doesn't eliminate jobs. It changes what the job should be.
Because much like I did with the beginning of our when I was preparing for our show, I leveraged ChatGPT to make me appear smarter. Those people can leverage AI. So AI is it doesn't necessarily run independently, in parallel, right? You can leverage it in your work, in theory, with while you're making those decisions. You could, in theory, I would get the AI opinion, and then you can then spot check or either that or move through those decisions so much faster, because AI is doing the crunching. The hard work of getting it kind of down to an either or, and then the human can kind of be the referee in the final analysis.
Yeah. So and I think we should use this as the starting point for a future episode. I'm sure. Look, there's no end of topics that we can talk about, and in fact, if anybody survived through listening to the entire podcast and they've got an idea of something they want us to look at, contact me, because I'm happy to drill down into if you've got something that you think is interesting as a listener, let us know and we will look into it.
Yeah, I'll tell you what, I find all this interesting, and I love talking to you, David, and I'm looking forward to talking to you in our next information risk podcast. If anybody has any questions for David, by all means, connect with him directly at Knowledge Integrity, or we have contact information in the description. We also have links to all of the articles that David referenced in the description. And ultimately, this is a production that is from Solutions Review and Insight Jam. And we would encourage everybody to go to Insight Jam, because David's there as well. And you can connect with him there and have these conversations in a very direct way. So good fun. I love it, David. I'm looking forward to keep going. You're very gracious in allowing me to kind of just blather on sometimes, but I can't help myself.
No, these conversations are great, and I'm looking forward to having many, many more of them.
All right, great. Well, thanks again for the time today, and talk to you soon.
Thanks.